This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
Welcome to the human side of healthcare. Hope you're having a great holiday week. And you know, Thomas, always good food at the holidays.
Yeah, and you always reach over there with what? The G word, guilt. It's like, oh, I shouldn't do this. Well, we have a really good solution today.
You know, that's true. And, let's don't demonize the food that we eat. Let's have good, healthy eating patterns, and let's learn from an expert.
This is Dr. Ruby Shah. She's an internist and obesity specialist at Texas Health Presbyterian Hospital of Plano and the founder of the Vitality Weight Loss Institute. Okay, Dr. Shah, let's play a little game here. Let's play I want to lose 20% of my body weight. Going big or going home? Now, we've got to talk about what goes down the hatch. Would you just give us some categories of food? And I'd like to lay out 3 here. What absolutely should I not consume while I am trying to lose and then maintain the 20 pounds, the 20%? And then what foods are okay, but we're not going to make much progress? And then what are the best foods that you would recommend to help me achieve my goal?
Yeah, although before I start, I'll say with a caveat, we try not to try to demonize certain foods because at the end of the day, that sometimes leads to more restrictive behaviors. So what we want people to do is build a repertoire of food that build healthy patterns of eating. And that pattern of eating doesn't mean you have to 100% exclude certain foods. It's just that we want to minimize them. So we can have them on occasion, but it shouldn't be our predominant pattern of eating. So of the foods that we should absolutely try to avoid, it's going to be what we've talked about. It's the highly, highly ultra-processed foods. In fact, what's interesting about these foods is that scientists don't actually call them food. They call them technology because that's really what it is. It's techno-food. It's a substance made in a laboratory designed to be as rewarding as possible to the brain. Calling it food is something we use colloquially, but it's not really what scientists call. So I would try to avoid eating technology. If that makes sense.
What a great way to put it. I absolutely love that. We've heard walk the perimeters of the store and don't go in the middle, anything in a box, all of that. But you're saying technology. What a upgrade of mental image that is. Thank you. So then what would be on the list of, it's okay, but, don't expect miracles here. And I'd like to ask you specifically about fruit because I love fruit, especially in the summertime. But it doesn't seem to help move the needle.
So fruit's an interesting one. Maybe it's easier to start off with, we talked about things you should avoid and then things that we want to eat plenty of. And actually fruit is in that category. So the things I recommend we eat plenty of is going to be whole grains, vegetables, and fruit. Also lentils and legumes, would be in that category. So in general, what we want to eat plenty of would be unprocessed or minimally processed foods. So whereas, like I said, the techno-type foods would be ultra-processed and would be on the other end of the spectrum of the things we want to eat plenty of as are the minimally processed foods. And those are going to be things like fruit, all kinds of vegetables, legumes, lentils, and whole grains. And so the things that are going to be in the middle are kind of whatever would fall in that. So for example, soda. Diet soda is better than regular soda, but it's not as good as water. It's helpful in terms of kind of minimizing your calorie intake because obviously it doesn't have as many calories associated with it, but it really triggers hunger cravings and appetite cravings.
Excellent. Thank you. You covered both bases perfectly in such an easy way to understand. Now, I'm bringing my own stuff to the table here. See, I'm kind of getting, and maybe some other people can relate to this. What about portion control? Because you sit down, you want to feel full, and when you don't, and then you cross that line and, you've eaten too much.
Yeah, so definitely portion control is important, but as we all know, much easier, a lot harder to do than we think. So the things that do help with portion control are eating protein because it helps satiety. It really helps our hunger more than anything else. So that's why if you go to any registered dietitian or you're trying to lose weight, the emphasis on protein for several reasons. And one of the reasons is that it helps us feel full. The other thing that helps with portion control is eating vegetables, eating our whole grains because it has fiber in them, or even fruit in that category. So those are going to be the things that help with portion control. So when we're building, someone's plate or kind of addressing how do we achieve portion control, I always recommend eat those things first, because the more full you are on the healthier things, the easier it's going to be to not eat the other things on your plate. You want to leave kind of the more processed foods, things like, your breads, tortillas last.
What about eggs? And then what about dairy, including cheese?
Yeah, so those are fine. Again, I don't think there's been any negative research that I've encountered on dairy. Dairy is part of a healthy diet. Eggs are also fine, although everything is with caution. So if you have high cholesterol, I would probably avoid eating 4 or 5 eggs a day. Wouldn't recommend that. I would aim for a diet that's lower in saturated fats. And cheese is also fine, but cheese is one of those highly addictive processed foods. Anyone who's ever tried to quit cheese can probably relate to how hard it is to do. It tastes so good and it's so addicting. So as part of a diet that's already full of minimally processed foods, that's full of tons of vegetables and whole grains and fruits, it's not really a huge deal. It really depends on what is your overall pattern of eating. Now, if your overall pattern of eating is a lot of processed foods, a lot of takeout, not a lot of cooking done at home, it's not going to do much to our diet other than add a lot of calories. So it really depends on what your overall pattern of eating is.
Now, again, from a chapter of my own struggles with this is blood sugar levels. And I don't know, because I don't have a lab machine sitting at home to check it right away. But it seems like there might be times when blood sugar drops and you literally get the shakes, and that can tend to lead to overeating to try to balance that out.
Absolutely. And that tends to happen more with the highly processed foods. The highly processed foods are metabolized so quickly in our body that we get that sugar rush. So we really want to try to do is have foods with fiber in it to try to prevent that. To kind of have a slower blood sugar response in our body and a slower insulin release. So those are going to be foods, as I mentioned, that have fiber. So those are going to be things like vegetables, fruits that also have fiber, whole grains. All of those are going to be helpful in maintaining your blood sugar levels.
As we climb that ladder of life and get older, it gets harder, doesn't it?
Well, one of the things that we know from studies is that as we get older, our protein intake tends to decrease. So as people get older, we are trying to be cautious of recommending getting your protein throughout the day. But I think in Texas, when we talk about protein, so many of us think about that steak or chicken. But really, the plant-based proteins are going to be the biggest bang for your buck.
Such great information from Dr. Ruby Shah. She's the founder of the Vitality Weight Loss Institute in Plano, also works at Texas Health Presbyterian Plano. When we come back, we're going to talk about the long arm of COVID next on the human side of healthcare.
This is the human side of healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back. Thomas, we're going to talk about long COVID and heart complications here in a minute. We've kind of hit what I would call a level of reduction, but we can't seem to get below that. Our COVID numbers have leveled off.
Yeah, just scanning the headlines and then listening to what people are talking about, it seems like you call it an endemic, right? That it's there, it's something we're going to live with, but it hasn't tapped out.
You're exactly right. And I'm a little concerned as we look at Europe and other parts of the country, COVID numbers are going up. Ours thankfully have come down, but they've leveled off. We cannot let our guard down.
So the bottom line is every day in North Texas, every day in Texas, every day around the world, people are getting and, yes, unfortunately, still dying of COVID. And as I scan the headlines, one of the things that I see the most are these implications affecting the heart and the pulmonary system.
Yes, the long-term COVID residual effects and the heart complications are certainly something that we're having to treat. We're delighted that we're going to talk today with Dr. Lay. He's a cardiologist at Texas Health Harris Methodist. Dr. Lay, welcome to the show.
Thank you for having me.
To kind of set the stage for our listeners, would you first describe what is long COVID and some of the common signs and symptoms?
Sure, Steve. The long COVID is a unique condition. It is separate from the acute infection of COVID, and it usually occurs about 4 to 6 weeks after the infection. And there's a constellation of variety of symptoms that patients develop, which tend to be vague. It can be something neurological like headaches, tingliness, brain fogginess, can lead to depression. Patients often report being short of breath or having a decrease in exercise tolerance. As it relates to the heart, they tend to have symptoms of palpitations, chest pains, sometimes have GI symptoms like diarrhea as well.
Is it more prevalent in a particular gender?
Yes, when we look at cohorts of this new syndrome, what we find is women in general tend to be more susceptible to this, and usually between the ages of 20 to 50. Part of the reason some have speculated is that women tend to be more in tune with their bodies. And with long COVID syndrome, there's not any real pathology as it relates to some specific diagnosis that makes you pinpoint that this is the entity, but it's rather a constellation of symptoms. Others have speculated that women tend to be more prone to autoimmune processes and so tend to have more long-lasting effects from COVID.
When you have some of these complications resulting from long COVID, at what point in your mind do they truly become a serious medical concern?
That's an excellent question. I think what we need to separate is long COVID syndrome versus true pathology related to COVID. Specifically for the heart, for example, COVID, we know, infects the heart, and we find the SARS virus in the heart. And we also know that it can cause inflammation and cause serious conditions like congestive heart failure, where the heart muscle weakens, versus long COVID syndrome, which can manifest as that or just simply be symptoms similar to heart failure, though when we do testing, the heart function is normal, and there's nothing pathological in terms of what we find in testing or blood tests or imaging testing. And so it's a unique condition because it's a real condition because we see a pattern of these symptoms continuously described in patients who've had acute COVID infections.
So if a person is experiencing these complications, why in your mind is it imperative that the patients get to a physician and address these long COVID symptoms sooner rather than later?
I think on multiple folds, because there are chronic conditions related to COVID that may fall under the category of long COVID syndrome, or maybe its separate entity, which are really serious conditions like congestive heart failure or pulmonary fibrosis, which is scarring of the lungs. But also seeing a specialist and having multidisciplinary care is important early on because these symptoms drag on for a long time, and it can be taxing to the mind and the spirit. And so it tends to lead to conditions of excessive anxiety and depression, and we see that quite often.
So, we've been dealing with COVID for almost 2 years now. With the Delta variant, which has been the most recent serious variant we dealt with, would that have a more harsher impact related to heart complications?
The theory is yes, and it just has to do with the virulence of the virus. And when I mean virulence, it just means how potent the virus invokes an inflammatory response in the body. And what we do see is the Delta variant tends to cause a higher level inflammatory response, which then translates to more cardiovascular complications.
Are there other forms of treatment or developments that you see on the horizon for long COVID and heart complications?
I think the best approach to preventing or avoiding long COVID syndrome is basically not get COVID. And the best way to not get COVID is to be vaccinated. What we see in vaccinated patients is even when there is penetration of infection, which means you get the vaccine, but you still get a COVID infection, the illness is much more mild. And so the inflammatory response is much more mild. So the chances of you developing long COVID syndrome is much less.
For people that have developed long COVID syndrome and they're dealing with it, what advice do you give them of things they could do to help improve the quality of their life?
You hit it on the nail. The quality of life is very important. And I think early intervention is very important to maintain that quality. So when you're dealing with symptoms after your acute infection of COVID that tends to drag on, I think the first approach is to seek medical attention early on rather than wait for the reasons we discussed previously, which is one, making sure that there is not actually an acute pathology that's going on. And then two, dealing with the sort of chronic illness, which can be very taxing to your mind and your spirit. And so I think having medical attention to that and dealing with that early on prevents progression of your state of mental health.
You know, early in the pandemic, people were somewhat fearful to come to the hospital or even call 911. Has that improved?
I think if your question stems from the fact that patients were avoiding access to care because of fear of contracting COVID, I see in my practice that fear has settled down, where our outpatient practices have basically approached baseline pre-COVID. In the hospitals, I think probably for the last 2 months prior to this interview, we were inundated with Delta variants of COVID, and that occupied a significant amount of the ICU care. What we see now is that number has leveled off, but we still see the same number of other high acuity illnesses that come through the hospital.
You know, we've been going through this pandemic for the last couple of years. Obviously, you've done a great job talking about long COVID, heart complications. As we look at the total landscape of what we've been going through, and now we have more knowledge, what is really your bottom line advice as we continue to deal with COVID?
Well, I appreciate the open-ended question. I think the biggest message, and I think it's said it in different forms and fashions through the media, is really the vaccine is the crucial aspect of preventing long COVID syndrome, because it prevents statistically your likelihood of getting COVID or getting a serious infection from COVID. And so I understand that it's a personal choice for a lot of people who choose not to get vaccinated, but it's really been well proven in literature, and there's been over 500 million vaccinations given and safe. And I think that's the biggest concern a lot of people who are not getting vaccinated is the safety of it. And I think the data is out there at this point.
We've been listening to Dr. Tulay. He's a cardiologist at Texas Health Harris Methodist Hurst-Euless-Bedford Hospital, also part of the Texas Health Physicians Group. Steve?
You know, Thomas, great advice from Dr. Lay. You know, vaccines are a personal choice, so people need to make an informed decision, and it's clearly their decision. We can only give them the information we have, but at the same time, we have to respect each person's opinion, but we do give thanks during this Thanksgiving season that we have vaccines.
You know, I'm going to give you just a real quick little tease. I was talking to somebody whose daughter is a nurse at one of our hospitals in North Texas, and she sees this every day. And she was saying, Mom, most of the people in the hospital who are seriously ill are unvaccinated. And that's from, you say boots on the ground, clogs on the ground in the nurse's case. That's somebody that's seeing it every day. You're absolutely right. Hey, when we come back, we're going to talk to Dr. Angela Price. She's over at Children's Health and UT Southwestern Medical Center about childhood epilepsy and seizures. That's next on The Human Side of Healthcare.
Welcome back to The Human Side of Healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. With DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome to the human side of healthcare. We're going to talk about a topic today related to treatment of epilepsy, and we could not have a better expert than Dr. Angela Price. She's a pediatric neurosurgeon at Children's Health and also serves as an associate professor at UT Southwestern. Dr. Price, welcome to the show.
Thank you for having me today.
We're delighted to have you. And, we have listeners that may be asking themselves, could you explain to me exactly what epilepsy is?
Yes, I can. So when a child or when a person has a seizure, it can be a single seizure. This seizure could be a result of an illness. For example, as a child begins to get a fever and the temperature goes up, you can have a seizure from that. That tends to be really common in small infants. You can have a seizure from trauma. Often these seizures can be a one-time event or maybe a couple in someone's lifetime. That's not completely atypical or unusual. However, epilepsy is when these seizures continue to come. So they come even when you don't have a fever or even when you haven't experienced a trauma. And these seizures then, because they become regular, may require treatment. With treatment, often we will give medications to try to settle the seizures down once we've done the investigations to figure out why the seizures are coming. With medicines, if the seizures settle down with medicines, then you have a seizure disorder. Or it sometimes may be termed epilepsy at that point. But if you are someone who continues to have seizures despite your neurologist prescribing multiple medications, that is when you have a true diagnosis of epilepsy or intractable epilepsy. Intractable meaning we're unable to control it with any of the medicines or any of the treatments that are prescribed.
How would you say, for the most part, epilepsy affects and impacts children?
Unfortunately, has a really severe impact on children. If you have only one or two seizures, you can go through your life as if nothing has changed. However, if you start having frequent seizures, it can really be a problem. It can impact on learning at school. So you're sitting in school, the teacher teaches you something, you are starting to understand it, you have a seizure. Your brain can then no longer put down short-term information, short-term memory, and you forget what you just learned. And so you're having to constantly relearn information that has been given to you. This can result in poor grades at school, difficulty understanding the information. Ultimately, if the seizures keep going on, it can damage the brain and lower someone's IQ with time. The second effect is that even if we give medications to try to control the seizures, those medications control the seizures by dulling down the brain, by decreasing the activity of the brain. So that can also give personality changes, give learning changes, and make it difficult to perform at the level that you should be performing.
You mentioned seizure disorders, epilepsy, medicine. Are there other common treatments for epilepsy and seizure disorders?
So once a child has been diagnosed with epilepsy and has seizures, medicine is the first line of treatment that is given. We have many good medicines that are well understood and well recognized. Another treatment that your neurologist will try if the medicines don't work is the ketogenic diet. This can be quite a difficult diet for the children to have, particularly when they go to school and the other kids are eating donuts and cereal, and they're unable to eat these things. So it can be very, very difficult in school-age children. And then finally, a newer medication or a newer treatment is Epidiolex or CBD oil, and that's been in the news a lot more recently.
As the children are being evaluated and treatment options reviewed, when would you say surgery is considered and why do you feel it's needed?
Well, I'm going to walk you through a little bit of the planning that we do and the protocols that we use in order to decide how to treat a patient with seizures. So if you have a child that comes in with seizures, initially you will try the medicines. You may get an MRI to make sure that there's not a lesion or an abnormality in the brain that we think is responsible for the seizures. Then, if the seizures are controlled, we stop there. However, if the seizures are not controlled, then we start asking more questions and investigating further, because we want to determine if there's one particular area of the brain, a focal area, that we can say is responsible for the seizures, and then we might be able to attack that area of the brain. And that's where surgery comes in. So a patient who is having seizures, has failed medicines, will start having a number of tests. And this is called a phase 1 evaluation. In this phase 1 evaluation, your neurologist, and now it may be an epileptologist, so you may no longer just be seeing a regular neurologist. You may get bumped up to a neurologist that specializes in seizures, who is an epileptologist. The epileptologist may order special scans and look at your brain in a different way, to look at the metabolism of the brain, to see if there's areas that have high metabolism or areas that have low metabolism, and give us a clue as to where the abnormalities are. We can admit a patient to the hospital and put the EEG on and try to capture the seizures while there is a video camera on the patient. And when we capture the seizures, we can see what the seizures look like. That'll give us a clue at what part of the brain is active. We can also see exactly where the EEG is active and where the brain waves are active and the spikes are coming from, to see if we can identify one area of the brain that is an issue. We will then also do things like neuropsychological testing. We might do other special scans like MEG scans, PET scans, SPECT scans. All of these are tests that we do to try to determine if we can find one single spot of the brain. So then from that point, if we find a single focus, then these are some of the lucky kids, particularly if it is a seizure focus that is an area of the brain that I can take out safely. Then the child is presented at an epilepsy conference. We make sure that all the physicians that are involved with this type of epilepsy cases and surgery review the patient and determine that they are a candidate for the procedure. And then they would go to the operating room for me to remove that particular area of brain to try to cure the seizures. But if it's an area of the brain that we think it's coming from one spot, but we can't put our finger on it, we can't absolutely isolate it with certainty, then we go to the next phase where we'll put electrodes on the brain. So do a surgery, put electrodes directly on the brain itself. Or, more minimally invasive, we'll take these tiny little wire electrodes and put them in a number of different places inside the center of the brain, and do a lot of recordings of the brain to try to determine an exact focus of where the seizures could be coming from. Again, if we find an exact focus and it's an area that is safe for me to remove, then we're going to talk about removing it and try to cure epilepsy. What if we have someone who has multiple areas of the brain that are having seizures? So the left side is having some foci and areas that are spiking. The right side is having seizures coming from that side. That patient is still a potential candidate for surgery, but it's going to be some of the more palliative options. Another type of palliative option that we have is something that is called RNS, or responsive neurostimulation. This is one of the newer techniques that has come out. It's been used in the adult world for maybe around 5 years. In children, we've just started implanting these in the last few years. The FDA is still not approving them, but we now have some compassionate use in children. What this involves is an area of the brain that the seizures are coming from, so usually a focal area, but it's an area we can't take out. Say the seizures are coming from the part of your brain that is responsible for speech. I can't take out the speech area. Even if it would cure your seizures, I can't take that area out. So instead, I'll put an electrode on that area, or I'll put an electrode inside that area, and I'll connect those electrodes to a generator that is implanted in the skull. And this is a permanent implant, not a temporary implant. It's permanently implanted, and it records information from the area of the brain that the electrode is in, and then your neurologist can make wise decisions about the settings that we should be delivering stimulation to that area of the brain and hopefully settle down the seizures. One of the other techniques that is just coming into use in pediatrics, there's only been a few children that have undergone this procedure in the United States at this point, is something that's called deep brain stimulation. So again, it's electrodes that are implanted into the very center of the brain, into a very specific nuclei. From there, those electrodes can record activity, and with the generator that is implanted on the chest, it can also deliver impulses. Those impulses may be able to disrupt a seizure network. And if it can disrupt a seizure network, it might settle the brain down and prevent the child or the patient from having further seizures.
Thanks to Dr. Angela Price from Children's Health and UT Southwestern Medical Center for that great information. When we come back, we're going to be talking about a community program helping new moms.
Covering the healthcare topics that matter most to North Texas. This is the human side of healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome to the human side of healthcare. Delighted you're with us today. And today we want to talk about a topic related to extending maternal care after pregnancy. We're delighted we've got Dr. David Nelson with us today. He's the Chief of Obstetrics and the Maternal Medical Director at Parkland Hospital and Health System, and also serves as an Associate Professor at UT Southwestern Medical Center. Dr. Nelson, welcome to the show.
Thank you for having me.
You know, I think to kind of set the stage for our listeners, when you talk in terms of treating maternal patients, given maternal care after pregnancy, can you tie that in a little bit with the social drivers of health and how the community health needs assessment that Parkland did brought this to your attention?
Sure. I think it's a great question. The thing that I think is one of the most important take-home messages for our listeners is to understand that for many years in medical school, we've taught our students and doctors really the importance of maternal health care as it relates to the delivery event. Things like high blood pressure, bleeding, and infection were the classic killers of women throughout the history of delivering babies. What becomes important is to appreciate that in the last 15 years to the last 5 years, there's been a pivot or a change in understanding what are some of the causes of death in the relationship of delivering a baby. And what I mean by that is that the frame of reference over time has changed, meaning our focus is not just at the time of delivering the baby, but rather looking at the time and period in the months and weeks after birth. And in fact, when you change that frame of reference to 12 months after delivery, the common causes of death and serious morbidity to patients is not necessarily related to bleeding infection as much as it is heart disease, substance abuse, mood disorders, all important elements related to the health of women when changing the reference from just the period around delivery.
You know, that is a great definition that you gave in that 12-month period. So as we look at the community health needs assessment, what triggered Parkland to launch the project known as Extending Maternal Care After Pregnancy?
If we think back to the period before the pandemic, one of the things that we were very proud of is the work that goes on for prenatal care. providing access to care for women to have prenatal care to identify health needs like high blood pressure, diabetes, infection issues. All are important points of access to care. At Parkland Hospital, the access to care prior to delivery is remarkable in that it's 97% of women getting prenatal care before they deliver their baby. And this is because of an integrated health system that provides clinic care and community-based care as medical homes across the county through 10 different prenatal clinic sites. We've been so proud of that for so many years. Unfortunately, the focus has largely been on prenatal care and focusing on the birth. As I mentioned earlier, the risk of death when viewing maternal morbidity and mortality and changing that frame of reference from just the delivery period to then extending it to the full year after birth or 12 months after delivery really emphasize the point that things that are risks to patients are not necessarily things that have been detected through the prenatal period. Things like mood disorders such as depression after delivery, heart disease, issues related to substance use, things that are important but aren't necessarily detected in the prenatal period. And so part of the Extending Maternal Care After Pregnancy program was to address and provide access to care, just like during the prenatal period, to now after birth. And this becomes so important when you consider that many women lose their funding or access to care after delivery. When this program was initially launched, the focal point related to the Community Health Needs Assessment was really targeting an area of our southern Dallas County that really had some of the most challenging areas related to social needs, be it access to transportation, food insecurity, or even just access to basic healthcare services.
Great description of the social drivers of health and how you tie this in. You know, thinking in terms of post-delivery, what are some of the services that are available to women?
So the Extending Maternal Care After Pregnancy program really is designed to look at a couple of things. First, we need to understand what are some of the needs our patients may have. Some of them include social needs, things like diapers, wipes, access to food, transportation services. Others are specific to healthcare needs. And in fact, about 10% of our women that are a part of this program have identified to have healthcare needs like diabetes and high blood pressure. It's been such a great story to tell about prenatal care access and getting good healthcare outcomes for women with medical diseases through pregnancy. And unfortunately, once the baby is delivered, many of those resources dry up, funding expires, or simply folks are busy taking care of their family rather than themselves. This program is unique in that it leverages two distinct elements. One, a dedicated telephone virtual visit encounter for providers, as well as a mobile unit in the community that provides services in the community-based areas, providing healthcare resources like medications for diabetes and high blood pressure in the community to avoid folks having to travel to and from clinic sites.
You know, the Community Health Needs Assessment was done in 2019. It's 2 years later. COVID intervened. How many mothers have enrolled in this program?
So that's such a great point. The 2019 Community Health Needs Assessment identified significant resource barriers and needs for our community in specific areas. And when we look at the outcomes related to COVID-19 and the impact it's had on our communities, there's actually a lot of similarities related to our local health community needs and the disparities in care. And so, in fact, many of them overlap. One of the responses to the COVID-19 pandemic was expanding our use of virtual telehealth services to both prenatal care as well as to our Extending Maternal Care After Pregnancy program, meaning it's much easier to answer the phone rather than to have to travel across town, catch public transportation, and other things related to barriers to care. And so we've actually learned from some of these experiences, and I would view as one of the silver linings of the COVID-19 response is medical community care, understanding the importance and value of telehealth services. Since our program was developed through 2019 and launched in October of 2020, we've enrolled now at over 1,300 women to be a part of this program. And in fact, our enrollment rate exceeds 70% of women delivering in this program, which is a remarkable number. This has been really supported by not only the Parkland effort in response to the Community Health Needs Assessment, but also UT Southwestern, as it's a partnership between both organizations.
You know, a lot of our listeners, I'm sure, understood what you said, but what really brought it to my focus Recently, Kaiser Health News had an article, Down to My Last Diaper, and it talked about the anxiety of parenting in poverty in America. And I was shocked to see that 1 in every 3 American families cannot afford enough diapers. Obviously, from a physician's point of view, this economic stress must have a negative impact on the health of these mothers.
Absolutely. For folks that have children and have managed having a baby at home, they're well aware that in the United States, most babies use 6 to 10 diapers a day. And that can amount to a cost of up to $70 to $80 a month. And so the stress and strain of not having enough simple, essential needs for one's baby is clearly something that we would think of creating stress and strain and anxiety. As part of this program, we're actually now able to measure and quantify and show the direct relationship of not having these support care need essentials and the impact it has on raising not only scored anxiety, but also depression symptoms. In other words, this is one of the first times we've been able to show how some of the social determinants of health in our community can have a direct negative impact on the health of our mothers in the family unit.
Thank you, Dr. David Nelson, UT Southwestern Medical Center. Steve?
What a great show today, Thomas, and I hope you had a great Thanksgiving.
I did, and I hope you did as well. And boy, we sure got some good advice right off the bat today on what we can do about all that food that we ate.
Oh, we certainly can. And I hope our listeners all had a great Thanksgiving. Hope that you're going to have a good rest of the day. And please join us next week for the human side of healthcare.